Thank you for having me here to talk about my project, Improving Energy and Protein Intake via an Oral Nutrition Support Pathway in the Intensive Care Unit and Beyond. So I started this project 2.5 years ago, and it's currently sitting with the journal in the hope of being published. That's why I can't share my slides today. Before we get started, I just wanted to declare that I have no competing financial interests or personal relationships. So a bit of background. Malnutrition is a highly prevalent condition within the ICU, with studies citing rates of 38 to 78% upon admission to the ICU. Pre-existing malnutrition is associated with increased ICU length of stay, ICU readmission, incidence of infection, hospital mortality, and lower odds of being discharged from hospital alive. Compounding the pre-existing malnutrition is the catabolic nature of critical illness, plus the large protein and energy deficits that accrue over an ICU admission. Those patients who survive critical illness often lose weight, develop significant muscle wasting, leading to impairments in physical function. Studies looking at adequacy of nutrition following critical illness found patients do not meet their nutritional requirements for a variety of reasons, including reduced appetite, gastrointestinal upset, difficulty swallowing, reduced physical function, early removal of feeding tubes, and psychosocial issues such as delirium. Studies demonstrate that oral intake is the most common form of nutrition post-critical illness or liberation from the ventilator, with patients meeting on average between 34 to 83% of their energy target and 23 to 83% of their protein target. So we have a high proportion of pre-existing malnutrition, which is then compounded by the catabolic effects of an ICU admission and subsequent inadequate energy and protein intake, leading to a very vulnerable group of patients that are weak, have decreased physical function and morbidity that can last for months. Recent evidence suggests a more cautious approach to the provision of nutrition in the early stages of critical illness, with recent studies such as Nutria, Effort Protein, and Precise demonstrating worse outcomes for those patients receiving standard to higher amounts of energy and or protein compared to lower amounts. Therefore, providing more nutrition in the ventilated patient is not the answer. It is hypothesized that patients may be in a better position physiologically to metabolize nutrition post-acute phase of critical illness. We are also seeing an increased number of patients on oral diets due to a trend for less invasive mechanical ventilation and a greater use of non-invasive mechanical ventilation. Despite all this, there are no guidelines or studies with recommendations for patients on oral diets within the ICU or post-ICU. Although not conducted in the ICU, a large randomized controlled trial conducted in 2019 by Schultz demonstrated that protocol-guided individualized nutrition support significantly improves patient outcomes in a medical population. Their trial found 79% of medical patients met their energy goals and 76% met their protein goals with individualized nutrition support, compared to 54 and 55% respectively in the control group. Their study also showed a reduction in adverse clinical outcomes, including mortality. This suggests similar benefits may be expected if an intervention was implemented post-critical illness. So before I commence this project, I'll run through what was standard practice in the ICU I work at Redcliffe Hospital. That's just a little photo of our hospital, which is hopefully undergoing expansion in the next few years. So patients on enteral and parenteral nutrition were prioritised with local guidelines and blanket referrals in place to ensure patients were receiving the correct amount of nutrition. We did regular audits on patients receiving artificial nutrition to determine the adequacy of energy and protein delivery and also adherence to the feeding protocol. There was no nutrition screening for any of the patients. Patients on oral diets blanketly received a high-protein, high-energy diet in the ICU with a snack trolley, but this was often discontinued once they discharged from the ICU to the post-ICU ward. For example, if a patient had diabetes, they would go to the ward, the nurses would see this, and they would take off the high protein and put them on a diabetic diet. Dietitians also saw patients on oral diets if known to them from receiving enteral or parenteral nutrition or if they were referred. So in developing the research question, leading up to starting the project, I'd been attending different nutrition conferences and talks, and I'd listened to the researchers saying we needed to shift our focus from the acute phase of critical illness to the recovery phase, where patients may be better able to tolerate and metabolize nutrition. I therefore started thinking, how are our patients faring at Redcliffe Hospital? Who should we focus on? And I thought of a couple of groups. Should we focus on those patients in ICU or those that have been discharged onto the ward? Should we focus on those patients that had a previous mechanical ventilation, or should we focus on everybody? So in terms of the aims and outcomes for my study, the aim was to increase the energy and protein intake of patients in the ICU and beyond onto the post-ICU ward via the implementation of a multidisciplinary individualised oral nutrition support pathway. Secondary aims were to identify barriers to oral intake, to determine whether there were differences in adequacy evident between patients who received ventilation and those who did not, and across different wards, so between ICU and the post-ICU ward, and over time. The primary outcome was adequacy of energy and protein intake, and we looked at this in two ways. So first, we looked at the percent of estimated energy and requirements met, and then we also looked at the proportion of patients that met more than 80% of their energy and protein requirements. With methods, in determining how to best improve the intakes of these patients, I wanted to first understand the problem. So this involved doing some pre-implementation data collection before actually developing the intervention. So my study took on a prospective single-centre pre, post, before and after study design. I collected some pre-implementation data for 4 months between the 1st of September and the 31st of December in 2022. The data collected included adequacy of oral intake for all patients admitted to the ICU who were expected to be in ICU for longer than 48 hours and they needed to be on an oral diet. For those patients who were ventilated, we just kept an eye on them, and then once they were extubated and allowed an oral diet, we could then include them in the study. Data was collected for 15 days, and once discharged to the ward, we would follow them up on the ward and continue to collect data there. We asked nursing staff to complete food charts for us. We did this 3 times a week as we didn't think we would get complete data if they were having to do it every day. So we made a point of it saying that it's just for these 3 days, please. And then we also had dietitians and nutrition assistant, and our nutrition assistant did do the bulk of this for us. She would then go and verify the intake. So then she would collect the food charts for us, and if they were missing meals, she would ask the patients what they would have for that meal, and she would also verify what was written was true and add in any missed meals or snacks from home, etc. We calculated energy and protein provided from food and any supplemental enteral or parenteral nutrition and compared this to their estimated requirements. So we used 105 kilojoules per kilogram for energy and 1.3 grams of protein per kilo for all patients. Also, for those patients who ate less than half of their meals, we asked them why they couldn't finish their meals to gauge their barriers to oral intake. Post-data collection, we analysed the data, held meetings with different members of the MDT, so this included the nurse unit manager of ICU, nursing staff, nutrition and dietetic assistants, and the dietitians to develop a plan and a nutrition support flowchart to improve energy and protein intake via the oral route. We then embedded the flowchart into practice, and then we collected the post-implementation data to determine the effectiveness of the change. So then we collected this data from the 1st of September to the 31st of December 2023. So in the pre-intervention period, we had 56 patients who we monitored, and they on average consumed about 4.5 megajoules a day and 48 grams of protein. We found no difference in adequacy of intake between the ICU patients and those on the ward. We also found no difference in adequacy between those patients who had received previous invasive ventilation and those who did not. So I was a little bit surprised by this, as I had hypothesized that there would be worse intake in ICU, and I also thought, especially for those who had received mechanical ventilation, I thought they would eat poorer as well. However, it was just that everyone ate really poorly. So I guess it made it easy for us that we had the intervention across all of the patients on oral diets in ICU and continued it on the ward. So developing the intervention. So first of all, what we needed to do was we needed to consult the evidence and also discuss with the MDT to see what they're willing to do. Things we considered included oral nutrition supplements. There had been no studies to implement an intervention to solely improve the oral intakes of patients in ICU or on the post-ICU ward. However, there was an observational study by Emma Ridley who showed that patients who were on oral nutrition supplements consumed significantly higher amounts of energy and protein compared to those patients who weren't receiving any. So this was definitely something we were going to include in our pathway. I also looked at the success that Schutz had in that study I mentioned earlier in improving energy and protein intake through the use of individualized nutrition support involving dietitians. So involving dietitians in the pathway was something else to include. And there was also a call in the literature to involve the MDT in nutrition education and the encouragement of oral intake. Especially nursing staff, they're in a much better position than us as dietitians to encourage oral intake, as they're with the patient at every single meal and snack. So this is what the oral nutrition support flowchart looks like. So it's separated into ICU and then the ward. So it's multifaceted, involves lots of different aspects. So all patients in ICU and the ward are to have a high protein, high energy diet with mid-meals. Those patients on thin or mildly thick fluids could receive a low volume, high protein oral nutrition supplement at morning and afternoon tea. And these supplements were 125 mils. Those on thickened fluids received a nutritionally complete thickened supplement. So that would be moderately and extremely thick fluid patients. Nursing staff would complete electronic food charts. So in ICU, we have electronic food charts. So they were to complete these on all patients to aid us in screening. The dietitian was to review these food charts and do a nutrition screen on day 3 of oral intake. So this took the form of an MST, so a malnutrition screening tool assessment, and also looking at how much food the patients are currently eating. If they scored an MST 2 or more, indicating a risk of malnutrition, or they were consistently eating less than half of their meals, then a dietitian would do an assessment. On the ward, Nursing staff would do follow-up weekly malnutrition screening, and the patients would receive 2 nutrition supplements of their choice daily. So they received a slightly different supplement on the ward to what they received in ICU. This was just a logistical thing for our hospital, as our nutrition assistants were concerned that if our ICU patients on the ward were receiving a different supplement, then more patients would end up wanting that supplement, and we only had approval to use it for our ICU cohort. So some rationale behind some of the decisions that we made. So the high protein, low volume oral nutrition supplement we chose was the highest in energy and protein available to us. So 125 ml bottle contained 1,250 kilojoules and 18 grams of protein. We thought we could use this either via a med pass style, so giving 60 mils out at a time, or we could give the patient the whole single bottle. We decided, after discussion with our nutrition assistants, to do the single bottle. The nutrition assistants work 7 days a week. They blanketly visit the ward. They'd be giving the supplement to the patients, and we wouldn't miss a dose. Whereas trying to get the doctors to write this supplement up med pass style for all the patients when they're being admitted, it's not going to be at the forefront of the doctors' minds. If it was up to the dietitian to do it, we would miss it on the weekends. So we thought it would be more successful for us to have it on our supplement trolley and the nutrition assistants provide it. They were also educated on the importance of the supplement. So if the patient was a bit resistant to trying it, then our nutrition assistant would give them some education on why this drink was important. We also provided education to the nursing staff on the wards as well, so that they could encourage oral intake and the intake of the supplements. In terms of nutrition screening, no tool completely met the needs of our ICU population. So there was the Nutric tool. However, this focuses on the severity of disease and more suited to ventilated patients, whereas our patients are awake and eating. So we wanted a tool that focused on more nutrition-specific variables. So we decided to go with the MST, the malnutrition screening tool, as it's widely used in our hospital. However, if the tool does pick up the pre-existing malnutrition or patients that may have had a length of stay of a couple of weeks, but it may not pick up patients that are acutely eating poorly. That's why we decided to add in assessment of current intake as well. So on to our results. These are the baseline characteristics of the group. So 56 patients in each 4-month time period, and the characteristics were even between the groups. So the average Apache 2 score was 18, reflecting a moderate severity of illness. About a third of the patients had received previous mechanical ventilation and artificial nutrition. And these are our main results. So post implementation of the oral nutrition support pathway, energy intake increased by a mean of about 2.5 megajoules and 26 grams of protein a day. Pre-implementation, we only had about 20% of patients meeting more than 80% of their energy requirements and 13% meeting their protein requirements. Post-implementation, this increased to 60% of patients meeting more than 80% of their energy requirements and 46% meeting more than 80% of their protein requirements. Just noting the sample size was too small to show any differences in any of the clinical outcomes. This graph here shows how a patient's energy and protein intake increased over a patient's hospital admission. The other aims that we looked at were in relation to differences in intake based on whether they were in ICU or post-ICU or whether they were ventilated, and there were no differences in those groups. In terms of barriers to oral intake, they did not differ between the groups. The main barrier overall was poor appetite. About half of patients reported this, followed by gastrointestinal disturbances such as nausea, vomiting, diarrhea, dislike of the hospital meal, and then psychosocial deficits such as delirium. In terms of limitations, the limitations of the study is that it was observational in nature, therefore no randomization that can increase the risk of confounding. We used sequential group recruitment, which may introduce bias from time-based changes. However, our study only lasted the 16 months. Participant bias is possible due to the patients being aware of their intakes being monitored. Dietary intake was not recorded daily. We did this 3 days a week and assumed it to reflect full intake. We had slightly different nutrition strategies in ICU versus post-ICU, and that was because of the logistical reason of providing the supplement on the ward. We didn't have discharge weights for all patients, so only available for 66% of the patients. And then it was a single site study, which limits generalizability to other centres. In terms of significance and translation into practice, to the best of our knowledge, this is the first study to implement a nutrition intervention that increases energy and protein intake solely via the oral route in a critically ill and post-critically ill population. The effectiveness of the intervention can't be put down to a single component. Rather, it was the nutrition support chart was multifaceted. The multiple changes included were the universal prescription of the energy and protein dense oral nutrition supplement, the high protein diets, nutrition monitoring, screening, dietetic assessment, and also education by the MDT. Further work is required to assess whether a similar intervention across multiple sites could demonstrate similar results and impact clinical outcomes. In terms of next steps, we have embedded this pathway into practice in our ICU at Redcliffe Hospital. I also commenced my PhD this January under the supervision of Leanne Chappell at the University of Adelaide. So I'm doing that remotely, and we're undertaking a program of research aimed at improving nutrition intake in patients on the post-ICU ward. And this is funded by a Medical Research Future Fund grant. So just some acknowledgements. Thank you to Nutricia for supplying the 40-SIP compact supplements, to the Redcliffe Hospital Private Practice Trust Fund Advisory Committee for providing a research grant, the Redcliffe Hospital Dietetics and ICU Department for assisting with and supporting the project. And just note, these funders had no part in the study design, conduct, or data analysis and did not have any authority over these activities.
I'm going to take the next 20 minutes or so to go through 3 case studies with the aim for you to come away from this to be able to list some of the indications of use for low volume oral SIP feeds, to be able to identify types of patients who are likely to benefit from low volume ONS, and to hopefully gain some practical tips for use of low volume oral SIP feeds. So case study 1, probably a scenario not too unfamiliar to many of you. An 85-year-old female referred to us, dietitians, due to weight loss and poor oral intake. This patient had been in hospital for a month prior to this referral coming through. It was actually due to transfer to a transitional care bed, so a bed in a rest home, but still under our care. She'd been admitted 4 weeks prior due to a fall at home or going to the bathroom. She sustained a left proximal humerus fracture and a fracture of her left neck of femur, for which she underwent surgery. So you can see there, not too shabby for an 85-year-old in terms of past medical history. She does have some polypharmacy going on, but I'm sure you've seen worse. But of note there, she was charted a 200 ml bottle of ONS TDS by the physicians during her inpatient stay. Now, anthropometrically, this patient was low in body weight before coming in. Looking back on her GP record, she'd been losing weight over 2.5 years, slowly, of around 22% of her total body weight. And unfortunately, during her inpatient stay, she lost nearly 10% of her total body weight. And now with a BMI of 17, wasn't in good shape. She did have an MST done on admission, which she scored 2 for, but no referral to a dietitian had been made. I conducted an SGA on her for which she scored C, with pretty significant loss in lean muscle mass and fat stores. In terms of her nutrition impacting symptoms, these were pretty minimal. Her main one was just a reduced appetite, which is not uncommon for this age group at all, and this had been reduced further during her inpatient stay. So you can see there her energy requirements there and her protein needs. In terms of her oral intake, feedback from her notes in hospital, she'd been on a standard menu. She'd been charted the 200ml bottle of ONS TDS, getting a mix of flavours. Reading through the nursing notes, there were no food records for this patient, but by and large, comments like picking at food, she was managing at most quarter of her meals, at most half a bottle of this ONS a day, refusing ONS after midday, often refusing meals altogether. Meals were large and overwhelming. She was eating some food brought in by her whānau or family, for example, half a scone or a plain biscuit. But in balance, her nutrition intake was really suboptimal, 40% of her minimum needs at most, I estimated, in protein, likely less than 25% of her minimum needs based on these food choices. In terms of nutrition diagnosis, malnutrition, inadequate oral intake, I could have listed about 10 different diagnoses, but we'll stick with those for now. In terms of the intervention, I really focused on talking to the patient, her whānau, and the nursing staff in the rest home about her SGA score and what this meant for her and her recovery. I involved the clinical nurse specialist as well, who was dipping in and out of the rest home. We focused around her goals, including increasing her oral intake and her weight goal, which was ideally to try and get her back to her pre-admission weight. She was put on a high-energy menu, fortified foods, including soups, which she'd had enjoyed as an inpatient. She was put on between-meal snacks, and we were doing some of our basic food-first approach. I stripped right back in the evening, just sending her a dessert and cheese and crackers, because that's all she could really face. And I went straight in with an ONS. I chose a low-volume ONS, charting her just 2 a day. And what I did for this patient was chart it half a bottle 4 times a day, something that was going to be achievable for her. We got her on food records and, of course, some weekly weights. Now, in terms of some of the practical aspects with her monitoring, we cycled through the different flavours of the ONS. The nursing staff were brilliant in doing this. And patient identified one particular flavour she loved, which was a neutral flavour, so sort of a vanilla flavour, but not so sweet. We worked out timing of her low-volume ONS. So 3 lots of her half bottle she actually took with her 3 lots of medication. She was still having pain medication quite regularly throughout the day, and the other half bottle we fitted in mid-morning for her. And this patient actually reported that the low-volume ONS actually helped her to take her medications, and we've actually had this particular low-volume product validated by our lovely SLTs here at Tauranga Hospital. According to IDSI criteria, it is a level 2 thickness or mildly thick fluid, so that's a really good one to keep up your sleeve for when you have patients with dysphagia. And, of course, we just looked at those set times, treating this ONS like a medication and very much separating it out from food and snacks. The results, and this is showing a lovely trend here with her weight. So she bottomed out there in December when our referral came through, but over the course of those 2 months, we can see a beautiful trajectory upwards, surpassing her pre-admission weight. So case study 2, a 62-year-old Māori gentleman referred to us on day 4 of admission due to a reduced oral intake, weight loss with an MST of 4. Now, he'd been admitted to hospital due to ongoing nausea, vomiting, poor oral intake and fatigue, with a background of stage 3 colorectal cancer, for which he'd been receiving a chemotherapy. And his last round of chemo had been 8 days prior to this admission. Anthropometrically, certainly for a 62-year-old Māori gentleman, this BMI of 20.6 is low, and he'd had over 10% total body weight loss in the course of 2 months, which is pretty significant. I did an SGA on him. He scored a B with moderate malnutrition. He had significant muscle wasting, particularly in his legs. In terms of nutrition impacting symptoms, I think these were listed in his admission criteria, but nausea, vomiting, early satiety, he was hugely fatigued, and he did have significant altered taste sensation. You can see his requirements there. In terms of his oral intake, unfortunately, he'd been off many protein-rich foods, and this was due to taste and texture aversion, and particularly the smell of these cooked protein foods. His lovely oncologist had tried various things with them, including other brands of ONS, and here in New Zealand we have 2 fully funded products and several partially funded products. Unfortunately, this patient was dealing with these symptoms and he just was completely off anything, and he now had an aversion to ONS when I met with him in hospital. In balance, his intake was carbohydrate rich, protein poor, but overall his energy intake, I estimated at around 55% of his minimum needs, and like this last case study, less than 25% of his protein needs. Nutrition diagnosis, certainly inadequate oral intake, unintentional weight loss. I really should have had malnutrition in here as well. In terms of the goals, symptom control was massive for this patient, and then of course meeting energy and protein needs during his inpatient stay, avoiding further weight loss, and for this patient who was very much committed to try to continue his chemotherapy, so it was about getting energy and strength to be able to get through this next session. In terms of intervention, the first thing we did was focus on symptom control, we being the MDT. He was on a combination of antiemetics, including metoclopramide pre-meals, and the palliative care team actually were involved and got him on haloperidol, which was really successful in breakthrough nausea in the early stages of his admission. I altered his menu to remove hot cooked meals because he was so sensitive to smell, adding scentless foods and snacks like custards and yogurts, cheese and crackers, and a protein sandwich. And I really focused in with this patient and his whānau around his nutrition needs, where nutrition was found in certain foods, and relating this to what his requirements were, and including what that equated to in ONS. And this actually meant that the patient came around and became open to a taste trial of low volume ONS, so a product that he hadn't used before. We tried the various flavours. We have 5 in our hospital, and he chose 3, but in particular he found the mocha flavour was one of the few things that actually tasted as it should, so he had the majority of his ONS in that flavour. He preferred it chilled, and he took them with a straw, which again is quite a common thing I find. It helps improve palatability for patients. And I charted these TDS for him, meeting around 49% of his minimum energy and 74% of his minimum protein needs. In terms of monitoring, this patient had daily bloods initially because he was quite high risk for refeeding, and then it was really keeping a close eye on symptom management, IV antiemetics initially and IV fluid support until he was managing both orally. We set food charts up for him, twice weekly weights, etc. Now, in follow-up, unfortunately, at 5 days of admission, he had lost a further 0.3 kilos. However, 6 days after this, so 11 days of admission and day of discharge, he had a net gain at this stage of 0.4 kilos, and he was managing everything orally. Follow-up down the track with him at 3 weeks. He had been self-funding the ONS, so this product, low-volume ONS, is not funded in New Zealand or even partially funded at this stage, but he'd elected to fund this himself. So he'd had a net gain of 3.5 kilos. His symptoms had improved significantly, and his variety and volume of food had increased. So to avoid taste fatigue with the product, we decided to drop this to 1 bottle a day for the time being, and then he was also open to trying some of the funded products. So case study 3, this one's a little bit longer. 72-year-old female referred to us for a reduced intake, post-op day 5, and they were questioning an ileus. This patient had come in for an elective procedure, a Hartmann's inflammation of colostomy due to a partially obstructing inflammatory mass in the sigmoid. Post-op, this was confirmed as cancer after biopsy. She actually ended up having to have an open procedure, and she went to HDU mainly for BP support. And unfortunately, 3 days down the track, her laparotomy wound dehisced. This was largely due to her being so overloaded. So it ended up the bottom part of her wound was open for some time. Past medical history-wise, not too major. Some anemia, that's probably in relation to her mass, hypertension. She'd had a knee joint replacement some time ago and a lumpectomy due to cancer. Anthrometrically, so this lady coming in was morbidly obese, grade 2. However, she had been losing weight for the 3 months prior to admission of around 12%, and this was unintentional. An MST had not been done for this patient prior or on admission. Had it been done, she would have scored a 4, high risk, and a referral to us. So we perhaps would have known about her a little bit earlier. She had an SGA completed on her, scoring B, so mild to moderate malnutrition. Now, her nutrition impacting symptoms were multifold. She had a distended abdomen. She had generalised edema. It was pitting up to her thighs. She had a 16 French NG tube in situ for drainage, of which she'd had 1680 mils out in the prior 24 hours. She had intermittent nausea despite the drainage tube. She was on high flow oxygen, which made having an NG tube in really uncomfortable for her. And she had normally had upper dentures, but these were out, and her lower dentures were missing in action. Some were at home, and she had this wound that had dehisced. So she was not in great shape. In terms of her diet, she had been nil by mouth now for 6 days, having fasted for a day pre-op. She'd had a reduced intake of less than 50% for 2 to 3 weeks prior to the operation because of this partial bowel obstruction. And overall, she'd had a drop in her intake for 3 months prior to her operation, just due to reduced appetite, abdominal discomfort. So she'd been skipping meals, just eating smaller meals generally, and avoiding certain foods, many which were protein rich. These are her requirements based on the adjusted body weight of 84 kilos, definitely aiming for the upper end of protein. Some would argue even more. You could go for 2 to 2.5 grams per kilo of adjusted weight. And her diagnoses, altered GI function, associated inadequate oral intake in relation to this. Obviously, she has an ileus, malnutrition, and we could have added more here as well. In terms of her goals, initially to meet her requirements via TPN until adequate oral or enteral nutrition could be re-established, and to support post-op wound healing and recovery. In terms of interventions, obviously to remain nil by mouth for now, correction of electrolytes. She did have a reduced potassium and phosphate, start some IV multivitamin or Syndrex, and she was commenced on TPN via a PIC. So 7 days on TPN or 12 days post-op, her large bore NG tube was removed. She hadn't had any output for 48 hours out of that, and it was hugely uncomfortable for her on this high flow oxygen she was still requiring. Her stoma hadn't really worked. She was passing some wind, but she was generally still very edematous, and so was her stoma. So probably an altered GI still with some delayed transit in relation to this. She remained in a cumulative balance of positive 10 litres with a weight of 112 kilos, so up 8 from her pre-admission or pre-op weight. Not surprisingly, she had an albumin of 14. She wasn't helping with the fluid side of things. Her laparotomy wound remained partially open at the bottom. The surgeons were happy for her to trial some free oral fluids at this stage, and there was still very much a big focus on optimising her fluid management, so rationalising her IV ads with the medications, aiming to transition these to oral if we could, and of course looking at her TPN as well. We're always wanting to reduce or stop TPN if we can, but obviously this was also to try and assist with her fluid management. She, of course, had no appetite. She was fatigued, fluid overloaded. She'd had a tray of free oral fluids or 2 up before I saw her again, and she was just so overwhelmed with it. In Tauranga Hospital, part of our free oral fluid trays, we have a 200ml bottle of ONS go up with each tray. She was just trying to sip at it, couldn't get through it, just put off completely by the volume of fluids that were coming up to her. However, she was really adamant she didn't want an NG tube, a fine bore for feeding, if possible. Again, she'd only just got her large bore out, and she was still requiring high flow O2. So, in terms of intervention, again, looking at this patient-centred side of things, is I talked through with her, what do you want in your tray? So we stripped everything right back, yogurt at breakfast, custard at lunch, plain milk for dinner. And then I introduced a low volume ONS for her in a way that sort of would mimic what I would do via an NG tube. So basically 60 mils or half a bottle of the low volume ONS Q2 hourly over 14 hours, so 6 a.m. to 8 p.m. I wasn't expecting her to get up every 2 hours in the middle of the night to drink, but this would roughly meet around 42% of her energy needs and 50% of her upper end of her protein needs just with this ONS regime. And she managed this beautifully, bless her. And so after 24 hours, I was able to drop her TPN to 50% of her needs. Day 15 post-op, she's still overloaded, but we are starting to mobilise some fluid. Her laparotomy wound was able to be surgically closed at the bottom, and she was now off high flow O2. She was allowed to start on some solid food. Now, she had her top dentures in, but not her bottom. We still hadn't found these at home. So I put her on a minced and moist high energy menu. She still had a reduced appetite. She really had limited menu options, as one does in hospital anyway, and we was really only managing a quarter of her meals. So we had the discussion around a fine bore NG tube, whether, this would help her. I really was keen to get her off TPN. But she was very adamant she wanted to keep going orally. So I changed her low volume ONS to a full bottle, Q2 hourly. So in total, she needed to get through 7 bottles a day. And she was really just sort of partly putting her minced and moist meals to one side. She was really only picking at these. She trialled this for 24 hours, managed it, and I was happy to stop her TPN on day 16. Day 20 post-op, she's now eating half of her meals. I was able to reduce her low volume ONS to 4 a day. Combined food and ONS was roughly greater than 83% of her needs and around the 1.2 to 1.3 grams per kilo per day. Day 25, we found her bottom dentures. She was able to get onto a normal menu, high energy, high protein, which opened up a huge, much more of a range of food options for her and snacks. I dropped her low volume ONS to 3 times a day, and at this point I estimated she was meeting her full minimum needs. She'd mobilised her edema really well. She was 102, so 2 kilos below her pre-admission weight, but she still did have some edema on board. She was off all of her O2 support, starting to mobilise, and we're looking at transferring her to a rehab ward. That was a whirlwind tour of case studies. So just a summary around practical tips. I think this goes with any nutrition therapy that we're looking at initiating, but we need to manage symptoms first. I mean, that's, I think, fairly obvious, but important to say. And often we find at that point when symptoms are improving, patients are often open to a trial of ONS or even a reintroduction of ONS. And I would really encourage you looking at low volume SIP feeds, certainly as an alternative to enteral nutrition support, especially if you've got that reluctant patient at the bedside who really doesn't want a tube or a tube back in. Offering SUPs chilled and with a straw, it does improve palatability if you can do it. Encouraging testing sessions if you've got dietitian assistants, nursing staff who are able to help, healthcare assistants. It really is really useful thing to do, get the flavour right. And then incorporating ONS into daily routine, even using further reduced volumes if you need to, like half a bottle, but just more frequently. And then educating caregivers, whānau family and the patient around their nutrition needs and how to do this and what ONS actually means in the context of helping them meet their needs. Low volume SIP feeds are effective, patient-friendly tools. They're ideal for a large range of patients, and I think the common denominator for many of our patients, while they may have different disease states, surgeries that they've been through, often their nutrition impacting symptoms are the same or very similar. So low volume ONS is effective to achieve our clinical goals, which I've listed there, some of. But it really is key to get your team involved. Alicia mentioned this in terms of nursing staff. We've got healthcare assistants, dietetic assistants. It's all about patient-centred care, getting that timing right, and ongoing monitoring and evaluation. I've got here a plug for reduction in waste. I didn't focus on this too much, really. I mentioned it in passing, but in this environment where there's food insecurity and sustainability, we really need to be thinking about this. And there is good evidence out there to show that less is more, and that we do need to think about waste. If there's one thing that you take from my presentation, it would be, when we're thinking about low volume ONS, small volume, big impact. Less is more. Thank you very much.